ever wondered how much the cost of medicine drives up your medical costs? You only have to look at the bills that hopefully you're lucky enough to pass on to your medical insurer. But for many people who don't have medical aid, the rising cost of medicine is a deep concern. This is Tonight. I'm Bruce Whitfield, and tonight I'm joined by Michael Kleinrock. He is a Director of Research Development at the IMS Institute in the United States, to find out why you need to be considerably more cognizant of the rising cost of medicine. Medicine, it's getting better and better all the time. It's one of the advantages of being alive in the 21st century, Michael.
Yeah, it's a problem we'd like to have. There's a lot of innovation. There's breakthroughs all over the place. Cures for diseases that range from cancer, hepatitis C, things that have been hard to treat for years now are very easy to treat and very tolerable, very few side effects. So it's a great time for new medicines. But again, it's also a great time to wonder about how you afford them.
And that's also the great risk for the outlook, I suppose, of the pharmaceutical sector, because if they start getting a little bit too clever with their innovation, will anybody be able to afford the drugs they create?
Well, you know, this is a challenge for society. You know, society's asked industry to come up with innovations. 40 years ago, President Nixon called for a war on cancer, and 40 years later, we now have tremendous treatments for cancer that we never dreamed of before, and survival has improved tremendously.
And we can only hope that some of those treatments become a little less. The side effects of some of the treatments are pretty awful, but my sense of it is that that's improving even now. Radiation treatments and even chemotherapy treatments are more refined than they were, say, 20 years ago.
Absolutely. Treatments are much more tolerable today for many diseases, and the great challenge is how quickly they reach people around the world.
We look, though, at the cost of research and development, and we've got some of the world's biggest pharmaceutical companies that spend billions on creating what they call the ethical drugs, the originals, and they get a particular time frame over which the patents exist. Are those patents long enough to reward the patent owners, or do we need to extend the patents to sort of amortize the cost of the R&D over a longer period of time?
It's a great question. It's well above my pay grade to decide that kind of thing.
But is it theoretically something that we should be considering based on, if you've only got a short term to recoup your costs, well then the cost of the pill is going to be $10,000. If you get a little bit longer, we can lower the cost.
You know, I look at it a slightly different way. We've looked at, recently we've looked at how long and how much companies make back on their investment. And we found that very few companies actually make their return on investment on new medicines. In the last 20 years, it's changed from 3 out of 10 companies make their money back in the lifetime of their drug to now 1 in 10.
But surely that is the greatest risk to medical innovation.
Well, so do we have enough innovation? Are therapies good enough? So if we have high cholesterol, there are therapies that are older and now available as generics. Is that good enough? Or do we need the next new thing? Increasingly, we're chasing narrower and narrower targets. And that results in medicines that are increasingly more expensive because there's fewer people to take them. So our trade-off is, do we have enough medicines for enough of the conditions we suffer from? Or do we have rare diseases, we call them orphan diseases in the US, but rare and neglected diseases here in Africa? Do we have enough innovation for those to treat the people that need them?
So do we run the risk of getting into a pharmaceutical innovation cul-de-sac? Where it's no longer worthwhile to produce the new drugs because actually the patents have expired, the generics do the job of 5-year-old drugs. That's good enough, especially in public health systems, which are increasingly constrained.
We're starting to talk about this, but it may still be 20 years out. I mean, we're really looking at a situation for industry and for governments where there's a limited amount of funds for treating patients. Healthcare costs, if they continue to rise at greater than inflation in many countries, create a problem. And that problem is then, how do we decide who wins, who loses from a commercial perspective? How do we decide which patients get access and which patients don't? The worst thing I can imagine in our global society would be that someone would die because they can't afford medicine, and that happens every day.
Absolutely, and probably multiple million times a week as well. One looks at what the actuaries are telling us about life expectancy, and they say, well, a child born today, citing Princess Charlotte, for example, in the United Kingdom, she's got a very good chance of living till at least the age of 120, based on the fact that she's born into privilege and that medical science is evolving to such an extent that she will live at least to 120. That, for many people, is a scary prospect.
Well, it is, and you know, think today that we don't actually have effective treatments for Alzheimer's disease. Yeah. But the aging population means that people over 65 will more than double in the next 50 years. So what happens when we don't have treatments?
So you deal with cholesterol, you deal with heart disease, for example, yet the consequence of longevity is Alzheimer's. I mean, and that's the knock-on effect, isn't it?
Absolutely. So chronic disease treatments that use up our healthcare dollars and kick the can until you're older, you're still going to run into cancer when you're older. You're still going to run into the mental health disabilities. And when someone is disabled with something like Alzheimer's or other diseases of aging, they still have costs. They need nursing home care. They need care in the home. And so we don't yet have, here in Africa, we don't have a population that's very old.
No, we our problems on the other end of the demographic spectrum. We've got far too many young people.
The rest of the world is suffering from aging in a dramatic way. Now here we have a different problem, which is again access to basic medical care being even, and you have massive inequities in the treatment.
The nature of innovation is that it is irrepressible. You have scientists, people who spent their lives searching for great new ideas, great new patents, great new medical advances. One has this sort of, I suppose, maybe naive belief that progress can't be stopped. Or do we get to a point where we simply don't have the money to justify the progress?
You know, I think industry will react. I think that there will always be some adjustment. There will be mergers and shrinkage and capacity to deal with this. And I think, you know, the things that we're seeing now innovated are different than they were. We tackled large population diseases, heart disease, cholesterol, diabetes 20 years ago, and now we're tackling narrow diseases, rheumatoid arthritis, Crohn's disease, cancer. So when we tackle those effectively, and there's still a long way to go, then we'll go elsewhere. Right now we're seeing incentives for innovation in neglected diseases and in antibiotic resistance, which we desperately need.
That is one of the scariest problems for the next 20 years, is antibiotic resistance probably. We're, nearly 100 years from Alexander Fleming's great innovation, 1928, was 1929. Yeah. We're heading to the centenary of the discovery of antibiotics. We're potentially running out of time.
We are, and you know, we found in some of our research, so an example from the U.S. where we think we have the most developed medicine in the world, perhaps, a little cultural imperialism there. 5 years ago, 20% of flu diagnoses were treated with an antibiotic. Now, antibiotics don't work for the flu.
It's a virus.
Yeah, so why would you do that?
Well, you could argue Big Pharma was making an absolute killing out of it, but that's another one.
They don't make a whole lot of money on antibiotics these days. Many of them are generic. So this is medical practice, not necessarily following best practice. Yeah. We've reduced that from 20% to 6%. And other countries are doing the same, but it really requires tremendous focus to avoid that waste and that danger.
But it's running healthcare systems smarter then.
Oh, absolutely.
Yeah.
There's 8 to 10% of savings available globally. It's about $500 billion a year can be saved in healthcare globally if we just use medicines more responsibly. And that could be the difference to affording that next cure that we need to fund.
We've seen a phenomenal generics industry build up, for example, in India. South Africa's got one of the greatest generics producers in the world, the highly acquisitive Aspen Pharmacare, with which I'm sure you're familiar. Yeah. Generics have done a great thing in terms of broadening the spectrum by which the number of people who can be covered for basic illnesses. Is the generics industry ultimately destructive, though, to the ethical industry?
No, absolutely. The thing that the generics industry does for the ethical industry is that it keeps it focused on innovation. So in a country where the generics industry feeds on the end of patent life, they provide lower cost access to medicines to more people, and that innovation is then forced to move to newer things. So if you think of the industry as needing to continue to move forward to survive, then the generic industry forces them to do so. And so it's a symbiosis, and it's important.
20 years from now, Big Pharma is bigger or smaller? More consolidated? What is it?
Both.
Explain.
So we will see companies that have focused in specialty niche areas, and we will see companies that have focused on being generic, and we will see companies that have focused on specific needs of patients. We'll also see companies that are not focused purely on a pharmaceutical. So some of the biggest areas of innovation in diabetes care have nothing to do with drugs. They have to do with mobile apps and technology and Bluetooth devices.
And lifestyle.
And getting some of us fatties to figure out how to exercise and eat right.
Speak for yourself.
I was. But
you said us. I was a bit concerned there. In terms of your assessment of South Africa's pharmaceutical sector, we've got a couple of interesting companies. We've got a couple of interesting listed companies, the Adcock Ingrams of the world, the Aspens of the world. How do we feature?
So exciting exciting country, exciting companies, one of the stronger markets and industries in Africa as a whole, and a jumping off point for the continent. We're very hot on how these companies are developing and how they're growing. There's a real challenge in this country to figure out how to balance access for the whole as opposed to access to innovation that is easier for those who can afford it. And that's a moral, ethical challenge that the country has to face and balance.
But one looks at the massive achievement that was made, and I saw a quote from Elton John saying that he believes in his lifetime AIDS will be conquered, it will be a curable disease. 20 years ago, HIV and AIDS were a death sentence. The use of antiretrovirals prove the viability of and low-cost medical innovation to prolong life and a good quality life.
Technically, we're there. AIDS is a chronic disease today. If you can have regular access to medicine and medical care, and if you want examples, some of the earliest, very famous diagnosed patients, Magic Johnson, basketball player, are still alive and well today. The challenge is how we get that treatment to as many people as possible, and the healthcare infrastructure that supports a wealthy person does not necessarily reach people in a rural area without access or money. And so that's the challenge. Sir Elton John is absolutely right. It's possible, but it's not the drugs problem. It's a societal and a health system problem, and we have to get there.
That's a fabulous discussion. Thank you so much. Michael Kleinrock, he's a Director of Research Development at the IMS Institute in the United States. Thank you for watching. There'll be more tonight, tomorrow. Till then, bye-bye for now.